So the first drug that we are going to discuss that can lead to bleeding is warfarin. Uh, we have discussed that warfarin inhibits the reduction of vitamin K to its active hydroquinone form, and vitamin K is required for carboxylation of factors 7, 9, and 10. So when vitamin K is not converted into its active form, factor 2, 7, 9, and 10, they will not form, resulting in the deficiency of these clotting factor, and the person blood will get thinner or he will get a tendency to bleed. Now, warfarin is a medication that is used as an anticoagulation in different conditions, such as venous thromboembolism, atrial fibrillation, and someone with mechanical heart valves to prevent thrombus formation. So the indication, there are three important indications for the use of anticoagulation, such as warfarin. One is venous thromboembolism, atrial fibrillation, and the third one is mechanical heart valves. So what is a target INR in these different conditions? The target INR in venous thromboembolism is 2.5. And if venous thromboembolism is recurrent, then the target INR will be 3.5. And in atrial fibrillation, the target INR is 2.5. And in mechanical heart valves, the target INR is 3 to 4, is between 3 to 4. For mitral valves, the target INR is usually higher, that is 4. And for aortic valves, it is low on the lower side, and that is 3. So these are the target INR in case of warfarin.
Doctor, can you repeat the heart valves? Can you repeat?
For heart valves, remember that the range is 3 to 4. For mitral valves, because there, if someone has a mechanical mitral valve, then the chances of thrombus formation increases. So that's why for mitral valve, the target INR is usually a little higher than for aortic valves. So 3 to 4 is, you can say, the target range for prosthetic heart valves. In case of mitral valve, it will be 4, and in case of aortic valve, it will be 3. In easy words, you can remember that for prosthetic heart valves, the target INR is 3 to 4. Patient who is on warfarin are usually monitored using INR, International Normalized Ratio. What is INR, or International Normalized Ratio? Prothrombin time of the patient over the normal prothrombin time. So INR is calculated by dividing the prothrombin time of the patient over normal prothrombin time. Remember that warfarin has a long half-life, and to achieve a stable INR, it takes several days. You can see here in this paragraph that warfarin decreases the synthesis of 2, 7, 9, and 10, as well as protein C. Remember that protein C is a natural anticoagulant. Remember this point. Uh, because of this effect of warfarin, because initially in the 3 to 4 days in the start, it is a procoagulant, that it causes coagulation because it decreases the synthesis of protein C, which is a natural anticoagulant. So that's why we need to bridge warfarin with heparin or low molecular weight heparin because of this effect. Because it decreases the synthesis of protein C. So in the starting 4 to 5 days, warfarin is not an anticoagulant, but it is a procoagulant. So that's why we need to give uh, heparin or low molecular weight heparin along with warfarin for the initial 4 to 5 days. So liver enzyme inducers or inhibitors, they can interfere with the warfarin action. Enzyme inhibitors will increase the effect of warfarin, such as amiodarone, ciprofloxacin, and drugs such as NSAID, because they can displace warfarin from plasma albumin. So that's why using NSAIDs along with warfarin is not recommended. NSAIDs can do two things. One is that it can replace warfarin from plasma albumin, and the second is it can inhibit platelet function. So that's why using NSAID with warfarin may increase the risk of bleeding. What are the side effects of warfarin? Warfarin can cause hemorrhage or bleeding. Uh, they are contraindicated in pregnancy because they are teratogenic, but they are not contraindicated in breastfeeding. So feeding mothers can use warfarin, but pregnant women cannot use warfarin. It can cause skin necrosis. So when warfarin is first started, biosensitive protein C is reduced. This leads to a temporary procoagulant state after initially starting warfarin. This is usually avoided by concurrent heparin administration. So that's why we usually give heparin along with warfarin for the first 4 to 5 days. So hemorrhage, teratogenic skin necrosis, and purple toes, these are the side effects of warfarin. What is the management when somebody on warfarin has a high INR? What we are going to do? So the first scenario is if someone on warfarin and develop major bleeding. Now, what is a major bleed? A GAT bleed or an intracranial bleed is an example of major bleeding. So if someone on warfarin and develop major bleeding, no matter whatever his INR is, you need to stop the warfarin, give intravenous vitamin K at 5 milligram dose, and transfuse prothrombin complex concentrate. Prothrombin complex concentrate contain concentrated factor 2, 7, 9, and 10. So if someone on warfarin develop major bleeding, then initial step is to stop warfarin, then give intravenous vitamin K at 5 milligram. And the definitive management or most appropriate management in major bleeding is prothrombin complex concentrate. And if prothrombin complex concentrate is not available, then we will give fresh frozen plasma. Because fresh frozen plasma can take time to defrost, that's why fresh frozen plasma is not preferred in case of major bleeding. So our first choice will be PCC, that is prothrombin complex concentrate, and if it's not available, then we can go for FFP. So major bleeding is only indication for FFP or prothrombin complex concentrate in case of warfarin toxicity. In all the other remaining scenarios, we will not transfuse fresh frozen plasma or prothrombin complex concentrate. The general point that you can need to remember about the management of high NR is that if there is minor bleeding or if there is no bleeding and INR is more than 8, then we will use vitamin K. In case of minor bleeding, if the INR is above 8, we will give intravenous vitamin K. Because it's a minor bleed, so we'll give reduced quantities of vitamin K, that is between 1 to 3 milligram. And then we will check INR after 24 hours, and if INR is still high, then we will repeat the dose of vitamin K. And if INR is more than 8 and there is no bleeding, then we can give oral vitamin K. So simple point is that if INR is more than 8 and there is minor bleeding, we will give intravenous vitamin K. INR more than 8 and no bleeding, we will give oral vitamin K using the intravenous preparation. And after 24 hours, we'll check the INR, and if it's still high, then we'll repeat the dose. So major bleeding along with vitamin K, PCC or FFP is given. Minor bleeding with INR more than 8, we will give IV vitamin K. INR with more than 8 with no bleeding, we will give oral vitamin K. And now a scenario in which INR is between 5 to 8. So INR is between 5 to 8 and there's minor bleeding, we'll give intravenous vitamin K. So whenever there is bleeding, either major bleeding or minor bleeding, we'll use intravenous vitamin K. If minor bleeding, the dose will be 1 to 3 milligram, and if major bleeding, the dose will be 5 milligram. And if there is no bleeding and INR is more than 8, then we can use oral vitamin K. And no bleeding and the INR is between 5 to 8, then we'll withhold 1 or 2 doses of warfarin. We do not need to use vitamin K if there is no bleeding and the INR is between 5 to 8. And if INR is less than 5, but it is still higher than the target level, then we'll reduce or omit 1 or 2 doses of warfarin and measure the INR within 2 to 3 days.
In major bleeding, what would be the range of INR?
In major bleeding, it doesn't matter whatever the INR is. Major bleeding is, you can say, a life-threatening emergency. If you does not stop the major bleeding, the patient may die. So the
Right,
INR does not matter in case of major bleeding.
right,
If a person is on warfarin and he has developed intracranial hemorrhage or he has developed gastrointestinal bleeding, then the management will be same no matter whatever his INR is, either 4 or 5, it doesn't matter.
right. Thank you.
You will consider INR only in case of minor bleeding. So after a fall, an elderly patient on warfarin and atenolol for atrial fibrillation was brought to ER. CT shows 1.2 centimeters cerebral hematoma. INR is 3.4. See, in this scenario, you can see that a patient is on warfarin and he has developed intracranial hemorrhage and his INR is 3.4. So it's a major bleed. So we will not look at the INR in this case. The management will be uh, uh, IV 5 milligram of vitamin K1 is already given. What is the next step after vitamin K? PCC will be given. Another example, an elderly patient with a history of atrial fibrillation on warfarin was found to have INR of 6.7. He is on warfarin. What should be done at the anticoagulant clinic? Now tell me, what should we do in this case?
Stop the warfarin and give oral vitamin K. No, I will withhold warfarin for 1 to 2 days. 6.7 INR, right?
Yes, INR is between 5 to 8 and there is no bleeding. So the indication of vitamin K is bleeding, either major or minor. So if there's no bleeding, then we do not need to give vitamin K. Is that right? So an elderly patient with a history of atrial fibrillation on warfarin was found to have INR of 6.7. So INR is between 5 to 8. He is on warfarin. What should be done at the anticoagulation clinic? We'll hold 1 or 2 doses of warfarin and then repeat the INR. An elderly patient with a history of atrial fibrillation on warfarin presents with non-stop epistaxis. His INR is 8.1. So INR more than 8 and minor bleeding. We'll give vitamin K only. There is no need to give prothrombin complex concentrate or FFP. So this was all about warfarin. Does someone has any question?